So we had the anatomy and the embryological aspects of middle meningeal artery last week, and now we are moving on to the technical and clinical aspect of middle meningeal artery embolization. And we have Dr. Sreenivasan sir, who is from Apollo Hospital, a senior endovascular surgeon with us, the chairperson. So basically, we will be dealing with the management of chronic subdural hematoma. So it is basically an encapsulated collection of blood between the dura and the arachnoid, and the incidence is around 17 to 20 cases per 1,000. And we all know that it is common among the elderly people, and the presentation will be like they will come to general medicine OPD, neurology OPD, neurosurgeons OPD with vague symptoms, with focal deficit or vague cognitive symptoms. And the main problem is that the recurrence after surgical drainage, and the recurrence is said to be from 11% to 33%. And the second point is that the pathophysiology is complex. Previously, it was thought to be just due to bleeding from damage to bridging veins. And this oozing of blood was not only the cause for chronic subdural hemorrhage, and it was now said to be due to inflammation of this particular layer, which is known as the border cell layer. It is actually the innermost layer of the dura. The dura basically have periosteal, meningeal dura, and as well as border cell layer. And beneath the border cell layer, there is subarachnoid space. So basically, the blood start collecting below the border cell layer. So what are the features of border cell layer? They are loosely adherent cells, no extracellular collagen, and there are enlarged extracellular spaces. So once there is a damage or breach in this dura mater, the border cell layers will get breached, and it activates a cascade of inflammatory pathway. The gross specimen of the normal as well as in patients with chronic subdural hemorrhage, there is huge difference in the appearance of the dura. It looks inflamed as well as having a large number of vessels. Here we can see the border cell layer has got a numerous neovascularization as well as collection of blood beneath. In the histopathology, all the layers are enlarged. The periosteal layer has got numerous vessels as well as sinusoidal capillaries forming in the neural cell layer, border cell layer, and beneath that the hematoma comes. And there are so many receptors being positive, which produce angiogenesis as well as inflammation. Here we can see the number of vessels in patient with chronic subdural hemorrhage is very much higher than that of normal dura. So due to all these factors, what happens is the branches of the middle meningeal artery within the periosteal layer will supply blood to the fragile sinusoidal capillaries, which get into a high proliferative stage in the border cell layer. So basically, the cascade are traumatic head injury, which split open the dural border cell layer, then inflammatory cell coming and trying to repair it, and a new membrane is formed due to activated inflammatory products. Then angiogenic factors comes, then blood leakage occurs, which in turn affect the prolongs the inflammatory process. Thereby, the chronic subdural hemorrhage is basically an active inflammatory process rather than a simple leakage of blood. So, in a nutshell, we have so many inflammatory cells and their inflammatory pathway, then a blood collection in the subdural phase with activation of fibrinolysis and plasmin activation. All these things go hand in hand. So we can reduce the inflammation by giving steroids. We can reduce the angiogenesis as well as inflammation by giving statin, and we can decrease the activation of the fibrinolysis system by giving tranexamic acid, and we can remove the hematoma by surgical method. So let's see what are the management of chronic subdural hemorrhage. One is surgical drainage. The different types of drainage are there: a simple burg hole craniostomy, twist drill craniostomy, and mini craniotomy with the subdural drain. And the issue with the surgical treatment is recurrence as for chronic subdural hemorrhage. So what are the incidents? See here in 325 patients. For 224 patients, there is no repeat surgery. For 32 patients, a single repeat surgery. 6 patients twice, and 2 patients had thrice. 2 patients had 4 times resurgeries. So among 325 patients, only 224 had complete resolution. Rest of the patient had repeated surgeries. And there are so many factors which determine the rate of recurrence, in which the percentage of reduction in hematoma thickness is the most important factor. For example, we can see there's almost 50% reoperation rate for in patients of very less reduction in hematoma thickness. And when there is more reduction in hematoma thickness, the reoperation rate is low. And based on different studies, we have so many other factors like male patient, bilateral hematomas, then chronic subdural hemorrhage septation, then a larger volume of SDH after the operation, then presence of pneumocephalus in post-op patient, then heterogeneous density in CT, mixed density in CT, septations, large pneumocephalus, and post-op midline shift more than 5 millimeters. So all these factors lead to more chance of recurrence. Second method of treatment is middle meningeal artery embolization. We can do preoperative, postoperative, and standalone therapy. We can come to that later. And for which the definite contraindication is severe symptom. In medical management, there are so many trials which has been done, which showed very less benefit for each of the medications. One is steroids. Steroids, due to the major adverse event, even though there is reduction in the hematoma volume, the net benefit was less. It is almost same with the tranexamic acid. It does not seem to minimize the recurrence of chronic subdural hematoma after Warhol surgery. And in perindropil, that is AC inhibitor patient also, there was no significant difference in placebo and post-surgical patients. And coming to the middle meningeal artery embolization, initially about the rationale. The main rationale is that we are dealing directly dealing with the inflammatory process of the chronic subdural hemorrhage by minimizing the blood supply to that particular area. As we all know that the oozing of blood is the main trigger for the inflammation, which prolongs the cascade. Here we can see that in a dynamic contrast CT, initially there is no leakage of contrast, then leakage of contrast comes, then both the septa become enhanced. So that means a continuous oozing of contrast is there from the chronic subdural space. And at the same time, we can see that the middle meningeal artery is very much enhanced on the side of the chronic subdural hemorrhage. So based on different this study, we can see that the average diameter of the middle meningeal artery is more for the hematoma side when compared to the non-hematoma side. So what are the definite indication, contraindication? Indication due to lack of any like need of any anesthesia, major surgeries, or and it can be done in a high risk patient. And we all know that most of the chronic subdural patient will be high risk because they are elderly with the multiple comorbidities, and most of the patient will be taking antiplatelet and oral anticoagulation, and most of them will be having recurrent and residual chronic subdural. So for chronic subdural hematoma as a whole, a middle meningeal artery is very much beneficial. And the main contraindication is that we all know that for the benefit to come into action, it will take at least 2 weeks, and maximum benefit at the end of 4th, 6th, or 7th week. So a significant neurological deficit will not get affected by doing middle meningeal artery embolization. So it is a contraindication. And in the CT, if there is very significant mass effect, we can avoid doing a standalone middle meningeal artery embolization. And there are particular guidelines for chronic subdural hematoma. If the patient is asymptomatic and size is less than 8 millimeter, hematoma size less than 8 millimeter, regardless of the without midline shift, we can try conservative. And asymptomatic more than 8 millimeter, we can do MMA embolization. Symptomatic with the midline shift, significant midline shift, surgery, and preferably MMA embolization along with surgery. And first case report was from Japan for a patient who need to undergo multiple sessions of drainage of subdural hemorrhage. In that patient, they have demonstrated this cotton wool appearance of the middle meningeal artery, which means the loose sinusoidal capillaries of the periosteal layer of the dura. And they have done middle meningeal artery embolization, and this was the CT, which was done 7 months after embolization. We showed significant reduction. And thereafter, so many case series came. This case series had a 5 patient. Here, we can see that there is no recurrence after embolization. And all these patients are refractory chronic subdural hematomas. Now, about I have already mentioned about cotton wool appearance. And if we are seeing cotton wool appearance in superselective angiography, it means recurrent SDH or propensity to form recurrent SDH, and indicates neovascularization. And along with that, if there is contrast pooling, it indicates leakiness of the membrane. And in this case series of 21 patients, we can see that the post embolization, there is no a single case of recurrence. Before embolization, all these patients was having a recurrence. These are refractory or recurrent chronic subdural hematomas. All the patient, there was no recurrence after the embolization. And another case series with 72 patients. Post embolization, the treatment failure was 1.4%. Before it was 27.5%. And yes, middle meningeal artery embolization for chronic subdural hematoma, a series of 60 cases. We have a very good follow-up outcome, and procedural complication was almost 0%. And reduction in size more than 50%, 68%. And the primary endpoint, that means who required surgery after embolization, was around 8.9%. And there are trials which are going on, which started in early part of 2022, in which they are comparing patient who underwent surgery with the patient who underwent surgery along with the middle meningeal artery embolization, and primary endpoint is recurrence of SDH within 3 months. So in nutshell, for surgery, there will be mass reduction in the hematoma, and inflammation will be either increased or status quo. Angiogenesis status quo. Success rate is 80 to 90%, and medical comorbidities, and patient having coagulopathy will be a contraindication. Medication, the evidence is very less and success rate is very low. And MMA embolization, the main pathogenesis is affected, so that the angiogenesis is very low, and success rate is even more than surgeries, and even in patient with more comorbidities. So the advantages: it addresses the underlying cause, it is minimally invasive, and it can then minimal anesthesia. Then patient, even we can continue antiplatelet and anticoagulation therapy. So coming to the technique of meningeal artery embolization, we all know that we can take only up to 5 French or 6 French sheath, so that we can very well use the radial approach along with the femoral approach, depending upon the technique you use in your institution. So the sheath will be a 5 French or 6 French. If you are using the gate catheter as the support catheter, then we can use 5 French. Or if you are using a larger 6 French catheter, you have to use a 6 French sheath. Diagnostic catheter for femoral approach, any catheter can be used as per operator preference. For radial approach, we can use SIM2 and SIM1 glide catheter. And if glide catheter has got a very less support while advancing through the carotid artery, you can use a regular type of SIM catheters. In support catheter, most of the time the diagnostic 5 French diagnostic catheter will be used as the support, but 6 French catheter can be used if the anatomy is a little bit confusing, and because the advantage is that we can take angiogram and rod map with the microcatheter and the wire inside, so that we have more space and we will get a good angiogram. So this is from a radial approach, cannulating the left carotid. After the wire, we will push the catheter up. First, we will take a common carotid angiogram, so that we can see the internal carotid artery, external carotid artery, and in this we can make out the middle meningeal artery here. So this is the middle meningeal artery from the internal maxillary artery. After that, we can take a rod map and take the wire up through the external carotid artery. This is the AP and this is the lateral view. And once the wire is inside, you can push the gate catheter or the diagnostic catheter up, and then we can take an external carotid angiogram, so that the middle meningeal artery will be visualized as the first branch of the internal maxillary artery, and this is the main trunk. Then it will go inside the skull to the foramen spinosum, and in the subdural space it will take a sharp turn, and it divides into anterior and the posterior division. So by identifying as the first branch of the internal maxillary artery, the artery which is going up and having a sharp turn and dividing into 2 branches usually. This is how we identify middle meningeal artery. So a closer view, this is middle meningeal artery. This is anterior and posterior division, in which have the frontoparietal branch, and posterior division divides into petroscamus and parieto-occipital branch. And after reaching the external carotid artery, we can take the micro catheter and microwire. Microwire is of O14, and microcatheter usually we take O17, and Vasco10, SL10, Ethylone10 are the catheters to be used. And we will advance the wire inside the microcatheter. Here we can see the wire is taken through the external carotid artery, through the internal maxillary artery, then gone up to the middle meningeal artery, and we are pushing the wire to the anterior division. And behind that, we can see the distal marker and the proximal marker of the microcatheter. Here is the distal marker, proximal marker. We have taken the wire out, and we have taken a selective angiogram of the anterior division of the middle meningeal artery. So then we can push the microcatheter further in order to cannulate this branch. So then we will pull out the wire, and we will take start embolization. The particles as well as liquid embolics can be used. Particles are either PVA, polyvinyl alcohol, or embospheres. Liquid embolics, onyx or NBCA or SCUD 18. Liquid agents, the advantage is they will, since they are liquid, they will have a deeper penetration, and it will cross the anastomosis and go into the other vasculature, distal vasculature to the capillary level, and it will avoid the delayed recanalization, and it will have an enhanced visibility during the procedure. And the main disadvantage is higher complication in case of anastomosis, because they can reflux back into the anastomotic pathways. So higher complication, but being careful, we can reduce those complications. The injection may be painful, so that the patient need anesthesia. The cost is higher because the material is having higher cost, and sometimes we have to use more than one catheters for cannulating each branches, and especially if it is bilateral, we have to use more number of microcatheters, because the microcatheter will get glued, and so that sometimes we may have to use the detachable microcatheters. Here we use PVA 100 particles, and PVA 100 particles are put in a bowl, and we will mix with the solution made by mixing saline and contrast in the ratio 3:7. 7 contrast, 3 saline. And we will mix the particle with a visual inspection against a bright light, so that a favorable mixer thickness we obtain, and we will take it in either 2.5 cc or 3 cc syringe, and we'll inject. And we inject in a pulsatile manner, so that we can see the forward movement of the particle. Here we can see the particle mixed with the contrast reach here, and then it will go distally, so that we can see the forward movement and also the reflux, and we will know when the distal movement stops. So when the distal movement stops, we will stop injecting the particles. It is at that point the vessel is getting occluded, and then we will flush the catheter with the saline, and after that we will take a angiogram. This angiogram is taken after pulling the catheter back into the this area, so that the angiogram is normal for this, and there is cutoff in the distal, from the distal half of this particular branch. So remember to flush the catheter in order to remove any residual particle. And then we will cannulate this branch with the wire, and microcatheter will be pushed, and we will embolize that branch also. Now, another method, especially if the patient is having incomplete occlusion, or as an adjunct to the embolization, we will use coil occlusion. Coil occlusion is done via the same microcatheter. We will push the coil. Here we have those per denser 3D, 3 mm, 6 centimeter coil. And we will detach the coil, and we'll be packing the coil at the origin, at the main trunk of the meningeal artery. So we should, last time we have already mentioned about different possibilities of anastomosis. So petrosal branch should also should be considered. Then anastomosis with the ophthalmic artery. We have to see that whether the ophthalmic artery is arising from the internal carotid artery before taking angiogram of the external carotid artery. If we couldn't see ophthalmic artery coming from ICA, there we should highly suspect an origin of the ophthalmic artery from the external carotid artery system. Now, this is an anastomosis with ophthalmic artery. So in this patient, if we have ophthalmic artery anastomosis, what we can do is push the catheter more distally, and we will take out this branch initially. So here we have injected the embolic agent, and we have taken this branch. And as the next step, we will push the microcatheter here. This is the marker of the microcatheter. Then we will take out this branch, so that this area is conserved. And if this patient has additional supply from ICA, we can put an additional coil at the main trunk of the middle meningeal artery. So we should know this, but these branches, that is the petrosal branch. Here, this is basically the middle meningeal artery coming as the first main branch from the internal maxillary arteries, going inside the skull through the foramen spinosum. And this is the petrosal branch. This is cavernous branch. These are the initial branches. Then it will divide into two, and we'll have the anterior trunk and the posterior trunk. Posterior trunk will be having a parieto-occipital branch and the petroscamus branch, and this is the anterior division. We'll be having the frontoparietal branch, and from this branch there will be anastomosis to the ophthalmic artery. These are the diagrams showing liquid embolic agent being so the visualization is very good when compared to the particle embolization. Here you can see the cast being formed, and this cast is very much permanent, and this is onyx embolization. So that was the technique. In our experience in Rajiri Hospital, we have done around 42 cases of middle meningeal artery embolization. Around 16 standalone cases was there. One patient with the fall headache with MRS1, and we did the middle meningeal artery embolization as standalone procedure. The main thing was the patient was having an immediate relief for headache, and 1 month follow-up having no additional symptoms. In that patient, we can see the middle meningeal artery was fairly larger in size, and this was the follow-up. There was slight reduction in the subdural collection. Second patient, CKD on hemodialysis, headache 2 weeks, and we did MMA embolization. The follow-up was okay. This is the middle meningeal artery. The follow-up was, it was bilateral. We did bilateral MMA. 3-month follow-up scan. There is complete reduction of the hematoma size. Now, third patient, the complaint was headache. middle meningeal artery was larger in size. This was the subdural collection. Third month, it became normal. Fourth patient, left-sided weakness, headache. Middle meningeal artery was not having a normal anatomy, but we could embolize, and third month follow-up scan was normal. And another patient, recurrent fall, behavioral disturbance, already on dual antiplatelet therapy, and after MMAE, he became asymptomatic from second week. So the collection was very less, and after embolization, that collection got relieved. And another patient, mental slowing and confused state, headache, and immediate headache relief. And second week, patient became normal. MMA embolization was done on the right side. So from this much larger SDH collection, the patient almost had almost a near total reduction in the SDH size. And seventh patient, mental slowing, unsteady gait, coronary artery disease, and started improving after a few days of MMA embolization. And this was the middle meningeal artery. And there was, this is the slight reduction. First month follow-up scan showing slight reduction. And next patient, liver disease with deranged INR, prolonged APTNR was there. And patient became ambulant from the second week. So this part of the hematoma got relieved. This part was persisting, but symptomatically he was better, and he is presently under follow-up. Another patient, behavioral changes and frontal CPS. 1 month follow-up scan has this progress. Another patient with CKD stage 5 diabetes, and 3 month follow-up scan was normal. Another patient, third month follow-up scan, even though patient had symptomatic improvement, the volume was not much reduced. Another patient, third month follow-up scan, there is reduction in the volume. Then another patient, we have done MMA, the patient is under follow-up. Then some of the patient who had already underwent surgery through burr hole, then due to recurrence, patient had to undergo MMA. So this was the first scan. This was the first scan, and this is the scan taken after the surgery. It's a contrast enhanced CT, and 1 month follow-up after MMA. So in this patient, we have done embolization along with the burr hole. Another patient, liver disease patient, patient was having a large subdural hematoma with the mass effect after surgery. Then 1 month after surgery, there was once again there was collection, and we did MMA, and thereafter the resorption occurred, and patient became symptomatically better. Another patient, this was the hematoma, and this was the image after surgery, and MMA was done along with the surgery. For this patient, bilateral subdural hematoma after surgery, then patient had recurrence only on the left side. Right side he got better, left side there was recurrence. So we did left side MMA, and after 1 month that side got relieved. Another patient, this was the first scan. This is after surgery, the bit pneumocephalus, a minimal collection, and after 1 month there was recollection. Then we did MMA, and by 2 months patient became better. The sulcal spaces became opened. So these are the some of the cases we did. So finally, MMA is a unrecognized but upcoming method of SDS treatment, especially a minimally symptomatic patient with who is elderly and having comorbidities. And another important point is that it can be done as an adjunct to the surgery. Then anatomy of middle meningeal artery is variable, thus potential for complication, but all the studies shows very less complication. Only few case reports showing loss of vision, facial nerve palsies, etc. But major case series is not having any sort of complication. And it is better to always take an IC injection to know the origin of the ophthalmic artery by seeing the choroidal blush. And anatomy of the MMA is to be assessed by superselective angiogram of the external carotid artery before going for the procedure. Thank you, sir.
Good. Wonderful and an elaborative presentation, Jayasankar. A lot of things have been covered quite in detail. Especially, I liked your initial presentation on the pathophysiology. I think that is the most important part of the middle meningeal artery embolization, because that led to the concept of middle meningeal artery embolization as a treatment for chronic subdural. Because conventionally, for years, people have been thinking about middle meningeal artery as a very, chronic subdural as a very simple disease due to rupture of the veins and then collection of blood. But that's not the case. It's an ongoing process due to an inflammatory response. And the inflammatory response, the body is fighting to resorb, and there is a secretion. So this conflict goes on and on. For some people, the resorption capability is much better, and the inflammation dies down on its own. In any chronic subdural, we take about 20% of the cases. It resorbs on its own. It doesn't progress. In about 80% of the cases, it progresses to form more mass effect and it becomes clinically overt. That's when the treatment has been done. And conventionally, treatment by burrhole and tapping, which is a very, very simple procedure, has been in vogue for a very long time. And for a new procedure to come and tilt the table, a lot of things happen. One has to be dead sure that this procedure is superior to the already existing procedure. One. Second thing is, there is a lot of apprehension among neurosurgeons about subdural being taken away. They are already apprehensive that coiling is taken away, aneurysm surgeries have come down, and whenever you talk about chronic subdural, the neurosurgeons in general become very apprehensive. I mean, I'm a neurosurgeon too. So we have to tell them that this procedure is special because it is specially designed for certain situations where it becomes tougher to deal with surgery. For very simple, asymptomatic, chronic collections, this can be done effectively. And for more difficult ones where surgery is difficult or there is high chance of recurrence after surgery, especially those patients on recent stents and dual antiplatelets and who has got coagulopathy, who has got liver failure, who has got coagulation abnormalities. In those patients, just simple surgery is a stupidity in today's world. I mean, you have to, if there is a significant mass effect, you have to tap it and go ahead with a middle meningeal artery embolization. If the patient is asymptomatic, you just go with a middle meningeal artery embolization. So this is an adjunct procedure or an add-on procedure, and it's an additional arm. For example, any glioma you treat with surgery followed by radiotherapy and chemotherapy. The other treatments are an add-on procedures. Ultimately, you're trying to cure the disease. Likewise, this middle meningeal artery embolization is a new arm in the treatment. It is not a replacement for surgery. There are few specific indications where you can use it effectively. So that's what we should drive home the point as. And the inflammatory initial, your presentation was very good. But one thing I do disagree with your presentation is there are no guidelines as of today. I mean, the studies are on and people have been trying to prove that it is effective, though the anecdotal studies from different institutions. So far, we have had a case series and institutional studies and then meta-analysis, but we have not had a head-on comparison studies. So we don't have an actual guideline. Guidelines have been proposed by various people. For example, 8 millimeter, less than 8 millimeter, more than 8 millimeter is all like an individual group proposed guideline. So it has not been an study group or like organizational guideline have not been proposed so far. And then as far as the embolization is concerned, a lot of times I do a bilateral middle meningeal artery embolization, even for unilateral collections, because we know that there are significant anastomosis between the right and the left on the dura across the midline. For example, even sometimes as a surgeon, when we do craniotomy to excise the membrane of the middle meningeal artery, chronic subdurals, sometimes you see these collections go in the interhemispheric region. Along the falx as well, the dura is effective in secreting. So in those cases, you will you assume that the opposite side comes into continue to secrete. So the results may not be great as we expect. In some of the examples you showed me, like they were at 3 months, some collections were there. And possibly if we do bilateral middle meningeal artery embolization in those cases, not being very aggressive, but just simple to block those small distal vessels, it will be very effective. That's my opinion. And I in most cases, I do bilateral embolizations, even in unilateral collections. And the first case done in 2000 by one of these Japanese guy, I think he did it in a case with leukemia where they did recurrent the tapping, and then the patient kept on collecting again, and they went ahead with this middle meningeal artery embolization, and that was quite effective. And then coming to anesthesia part of it, I think most of your cases, I think you're doing it under monitored anesthesia care. Is that correct?
Yes, yes, sir. Sedation.
Yeah, light sedation. Yeah, most cases it works, but sometimes when we catheterize the middle meningeal artery, patient will be moving around a lot because dura is extremely pain sensitive structure in our body. And inside the brain, it's pain insensitive, but the dura, especially the basal dura, when you put the wire and cross, the patient will have some discomfort and there will be pain. So the sedation has to be a little bit on the higher side. And if you think you have a good anesthetic backup, and GA is not a bad idea. For the comfort of the patient, just for the comfort of the patient, not for the safety of the procedure. And a lot of times, whenever I usually have a protocol in terms of angiograms. I take separate ICA injections always. I take separate external carotid injections, exclusive external carotid injections. Then I put my microcatheter up. I take a separate proximal middle meningeal artery angiogram, and then I decide on going further. And whenever I put the catheter in the proximal middle meningeal artery, most of the time, these vessels are very sensitive. So I inject a little spasmolytic, like a little nimodipine or something you inject. The vessels will stay open. It will not clamp down on you. And you can expect your particles to penetrate more deeper. So I always proximally keep my catheter, give like 2 ml of nimodipine, 0.1 milligram per ml, about 0.2 milligrams. You just inject very gently over 5 to 10 minutes. It will make your life easy in terms of further embolization. And then another technique you told me was like sometimes you use a 6 French catheter. I never had to use a 6 French catheter because here we are not going to use any intermediate or anything. So we just always go with the 5 French catheter, both through radial as well as from femoral, whichever way we approach. Always a 5 French catheter, and then the microcatheter. Microcatheter, my go-to catheter is obviously SL10. And then we can use Vasco. Vasco is a little stiffer. It's not very pliable. Whereas the SL10 is a great catheter. It helps us a lot in catheterizing even more curvy, sometimes, like more distal catheters. And if you're using Onyx, Marathon is a great catheter. If you want to go really
not
distal,
used. Not used so far.
Yeah, it is expensive, and Onyx, obviously, like Onyx again, another 50,000. So in affordable cases, sometimes we use Marathon is a great catheter for middle meningeal, because even the toughest of curves in the old days, like for dural fistulas, when we treat with liquid embolics, Marathon is a great catheter for meningeal artery catheterizations. As far as the particle size, I try to initially infiltrate with the once I'm crossed the all the anastomosis, skull base anastomosis, the ophthalmic anastomosis, and the petrous anastomosis. Once my catheter is more distal, I would like to initially inject 100 micron particles to get more distal into those smaller branches. Then I finish up. I usually I mean, I don't follow these principle of 3:7. I just mix 50-50 contrast, 50 saline and 50% contrast, and then the particles to have good dilution. And then we inject gently to infiltrate this 100 micron particles, which will go more deeper into those small, tiny branches. Once those tiny branches are taken care of, control angiogram is done, then I go with the particle size above, that is 150 to 250 contour or embospheres, and finish my embolization with those size particles, then move on to the next vessel. And you clearly pointed out about the seventh nerve, how to preserve it, the petrous branch of petrous branch of the middle meningeal artery, and then the ophthalmic connections. Most of the time, the ophthalmic connections that we see in few of the examples you showed me, usually anatomical disposition is that most of them are lacrimal gland branches arising from the middle meningeal artery, going through the canal called Hartel's canal in the lateral orbital wall. And very rarely they do communicate with the ophthalmic artery, but even otherwise, if it is even lacrimal branch, we need to preserve that, because we don't know what are the connections within the orbit, because our orbital connections are extremely variable. And that was well covered. And then you spoke about coiling. Generally, I'm not a proponent of coiling proximally because I do not coil it. Because the problem with coiling is that you're blocking your future roadway. Most of the times when you inject with particles, the middle meningeal artery over a period of time will reform and recanalize. Particles is not a permanent occlusion. And in future, you want to access for some reason or other, you can always access it. And proximal occlusion, the problem is angiogenesis will develop through collaterals, because dura has many branches, posterior meningeal, then you have the skull base branches, you have the falcine branch, then you have, like, from the opposite side and all those branches. So once you block it proximally, all those collaterals will become active. Just in case if there is a recollection, you'll have to only resort to surgery. You may not be able to embolize it. So proximal coiling is something I think we should avoid. And then there is another technique of injecting glue. It's called sugar push. See, what is done is that I've tried it in few cases. Here for sugar push, you may need a more distal catheter, or with the proximal catheter held little higher up. You inject glue, and at the same time your assistant through a side port pushes 5% dextrose, which makes this glue as tiny particles. With the sugar push, they really go more distal, and with one push of glue and one push of sugar, you can really get this middle meningeal artery embolized in a very quick time. So that is one technique that you can try. Yeah, I think apart from that, you've covered everything wonderfully well, and this was a very productive session, and I liked your presentation, Jayasankar.
Thank you.